Right, hello everybody. Welcome to Pediatric Grand Rounds. I'm going to hand it off to our Vice Chair for Education, Dr. Sandrain Van Schaik, to introduce our Grand Rounds for today.
Thank you, Dr. Hirsch. Good afternoon, everybody. It's an incredible pleasure to introduce today's speaker, a person who I've known for several years and is a special person in my life, and particularly my professional life, because of the role she has played in my ability as a simulation person to really expand what we're doing at the Children's Hospital and beyond in simulation by creating these fantastic teams. Our speaker today is Dr. Mindy Ju. Mindy is a pediatric intensive care physician here at UCSF, and she came to UCSF several years ago in 2016, actually, after she completed her pediatric residency and critical care fellowship at Stanford. We had come up with this idea that we're going to do a simulation fellowship, and Mindy was the first simulation fellow. I still don't totally know how I managed to convince her that she was going to be the pioneer in this area. But in a very short period of time, she didn't only do the fellowship, but did her master's in medical education through the master's in education through the University of California, Berkeley, became the simulation fellowship director herself, and then the director of our Children's Hospital simulation programs, as well as the associate education director for our campus-wide simulation center. And one of the reasons why it's personally so important to me, but I think also it's just a very good example of why mentoring is so fantastic, is that Mindy is one of those people who, when I first met her, I had some things to teach her and to tell her, and very soon after she got her feet on the ground and started to do work, she developed expertise and understanding of simulation and lots of other things way beyond my own expertise. And that's what advancing education at UCSF and worldwide, in my mind, is all about, people like her. So really pleased that she's here today to share with us her own journey and the things that she's learned to understand and the contributions that she's made to this field. When we asked Mindy to say a little bit like, how did you come to this? Where did your passion for this work come from? She mentioned that as a trainee, she saw firsthand the value of simulation as an educational strategy. And over the past few years, really increasingly recognized the need for training that goes beyond technical skills and value, and seen the value in practicing how we communicate and interact with one another to create a more inclusive learning and working environment. Hence the title of her talk, Exploring the Power of Simulation to Create an Inclusive Learning and Working Environment. Dr. Mindy Ju.
Thank you, Sandrain, for that introduction. Way more praise than I deserve, but thank you very much. So I'm really excited to speak with you today about how we can use healthcare simulation to create an inclusive learning and working environment. Just for disclosures, I have no financial relationship, no financial disclosures, but I do want to say that I do identify as an Asian American cisgendered female pediatric critical care intensivist, and this plays a part in how I interact with the world, and a lot of my experiences will be sprinkled throughout this talk, and so that has influenced how my work and how I have perceived the world and my work through this lens. So when I say the word simulation, I wonder what you all think of. I think many of you have likely participated in some form of simulation during your training to become a healthcare provider or in your clinical work. And simulation has become a pervasive part of the healthcare environment. And in our children's hospital, you might think of high fidelity mannequins that we use in our interprofessional mock code program, or practicing communication skills with simulated patients. Simulated patients, for those of you who may not know, are actors that are trained to play the role of a patient or sometimes parent in healthcare scenarios to practice communication skills. But one of the definitions of simulation is an educational modality with which the learner physically interacts to mimic an aspect of clinical care for the purpose of teaching or assessment. And the value in simulation, healthcare simulation, is that we have an experience that's in on a mannequin that we cannot do harm to. And we all experience this together. And through a situation called the debrief, which occurs after the simulation scenario, we give feedback to each other and do some self-reflection to create new frames or understanding in our mind of how a clinical scenario unfolded. It might be that we have a new idea of how to interpret vital sign data, and that changes our framework around septic shock. Or it might be that we have new frames around how we communicate with each other and how we should better use closed-loop communication. And we hope that we can learn from this debrief, which is the essential part of the simulation setting, and apply this to either a new experience of simulation or to direct to patient care, with the ultimate outcome of improving patient care. And so I also want to take some time to define what is the learning environment. And so the learning environment is broadly defined as the physical, virtual, and social cultural spaces in which learning takes place. And an exemplary learning environment prepares, supports, and inspires everyone involved in health professions, education, and healthcare to work toward optimal health of individuals, populations, and communities. In order to achieve this goal, exemplary learning environments are inclusive. They integrate diverse perspectives to promote collaborative learning and practice and prepare learners for the care of diverse populations and communities. And simulation can play a great role in helping learning environments achieve their goal of optimal health for individuals, populations, and communities. And today's talk, I'm going to talk about 3 ways that simulation can be used to do this. So the first being reveal biases that exist in healthcare, represent a diverse and inclusive environment, and address biases through training of healthcare providers. So as we transition to talk about how simulation can be used to reveal bias, I want to share a personal experience. So it was a weekend and we were rounding in the PICU on an oncology patient, and we were standing outside the room when a surgical subspecialty resident interrupted our rounds and asked, "Who's taking care of patient X, Y, and Z?" And then he looked directly at the tall bearded oncology attending and the tall bearded oncology fellow and asked them, "Are you the PICU doctors?" I then had to interrupt and say, "I'm the PICU attending, and this is the PICU fellow," pointing to the petite blonde woman next to me. And I'm sure many women and people of color listening to this have found themselves in similar experiences. And yet when I've explained this experience or described this experience to some people, I often hear them say, "That wasn't because you're a woman," or "That wasn't because you are younger, that wasn't because you are Asian American." And so I tell this story to say that it's challenging to show that bias exists because there's so many confounding factors in the real world and clinical environment, and people can say that your experience isn't necessarily related to bias, even though we all are feeling that it is. And so this is where simulation can be used to demonstrate that bias exists when others question whether it does. So using simulation, we created a laboratory experiment where we had more control of the factors playing into resuscitation. We video recorded 2 identical scripted simulation resuscitation scenarios with the role of the team leader played by either a male or female actor. We chose to study these code events because they're really how we teach people how to be leaders. I think in healthcare, it's a common platform for teaching leadership skills. And so we copied these videos and labeled them the team leader as a physician or a nurse practitioner, leading to 4 study conditions where team leader is identified as the female nurse practitioner, female physician, male nurse practitioner, and male physician. we recruited 160 residents from adult specialties, so internal medicine, anesthesia, OBGYN, surgery, and and emergency medicine. And we chose adult because the scenario was around an adult arrest. So residents received an email. They were randomized to see one of 4 of the videos that I had mentioned before. And then they were asked to fill out a tool called the Ottawa Crisis Resource Management Global Rating Scale that is an assessment tool commonly used to assess performance in resuscitation of critically ill patients. And there are these 6 subgroups. And so for the purposes of today's talk, I'm just going to be discussing the results of the gender portion. So we found that there was a statistically significant main effect of team leader gender on residence ratings in 2 of the crisis resource management domains, leadership and communication. And we found that it was a ½ point lower, females were rated a ½ point lower than their male counterpart on these 2 skills. And while the effect size was small or moderate, and the size of the difference, the point difference was small, it was still found to be significantly significant. So from this, we concluded that resident physicians at our institution rate female co-team leaders lower than males in leadership and communication skills. And this led us to ask the question of why. Why are they rating women lower or females lower? And so to answer the why question, we turned to qualitative research methods, which I love. It's my favorite. It's the best way to answer the question of why and how, to investigate the perceived differences between the 2 videos and to understand how these trainees develop their idea of an ideal co-team leader. And so we interviewed 24 internal medicine and anesthesia residents from UCSF and performed a semi-structured interview. And before I take you through the findings, I wanna take you through part of the interview process. So bear with me. We started the interview with this exercise and I'd like you to try it. So close your eyes and imagine you're walking into the emergency department and there's a code and process. There's a flurry of activity around the patient. A respiratory therapist is at the head of the bed, bag masks ventilating. A nurse is standing on a stool doing chest compressions, while another one is attempting an IV. There's another person pulling out the defibrillator pads and getting the pads ready. You see a pharmacist standing off to the side pulling out medications, and somebody in the corner recording all the activity. The co-team leader is standing at the foot of the bed facing the patient. Think about this person as having all the qualities of an ideal co-team leader. Now we're going to talk about them. So we started every interview of the 24 residents this way and asked them what characteristics that person held. And then asked them what they, at the end of that, after they described the characteristics and behaviors of an ideal co-team leader, whether that co-team leader was male or female, and whether they were somebody that they had imagined, a real life person that they have worked with or interact with, or if it was an imaginary person. So when I do this exercise, I actually picture a white male in scrubs and a white coat and a beard leading a code. He's an amalgamation of a doctor from the television show ER, that for some of you in the audience you might be too young to know that show, and of an actual real life ER physician that I work with through my simulation work. And so even though I am a co-team leader, I don't think of myself when I imagine this person, and I don't think of a woman. And it turns out that's very similar to how residents represent an ideal co-team leader in their mind. So we found that 15 out of 24 residents stated they thought of a male leader, 5 out of the 24 thought of a female, and 4 out of the 24 thought of multiple people of different genders. And interestingly, 3 out of the 5 who thought of a woman were actually thinking about the same chief resident in their program. And in fact, the majority of residents were thinking of a real person during the description of the ideal co-team leader. So this confirmed our suspicion that residents' cognitive representation of an ideal co-team leader is more frequently male than female. Yet even if a resident represents in their mind the ideal co-team leader as a male, it doesn't explain why females and male co-team leaders who are behaving similarly would be rated differently. So we then in the same interview, asked residents to watch the simulated resuscitation videos that I had shown you screenshots of earlier. Half of them watched a video where the co-team leader was female, and the other half watched the video where the co-team leader was male. And then we asked them to describe the characteristics and behaviors of the co-team leader. The co-team leader was frequently described as calm, in control, and assertive while recognizing the leader's responsiveness to feedback from other team members. These observations didn't differ whether they saw the video with the male or the female co-team leader. But interestingly, in the qualitative comments, residents negatively commented on the female resuscitation team leader's demeanor and nonverbal behavior. So in the first quote, she was very rough around the edges. She could have softened things. It seemed like a very hostile environment. It seemed like she was one everyone should be listened to and didn't include anyone. Second quote, she crossed her arms. She kind of had her back to some of the room at some time. Just a lot of her body language was very closed off. And I just bring up these images, screenshots again, to show that we actually, in the videos, scripted out the exact location and where they were facing and their body language throughout the videos. Yet the male actor was never described as having a closed off or hostile demeanor. So why is this happening? I think these findings can be explained by a social psychology phenomenon called backlash effect, which is defined as social and economic reprisals for behaving counter-stereotypically, and in this particular situation to one's gender. So I bring up this picture of Hillary Clinton from The Atlantic in 2016, because during that election season, there was a lot of discussion around her likability and the fact that she suffered and the fact that she did suffer from backlash effect. She has many of the traits of a conventional presidential nominee, and shared many of these traits with the other candidates. But her stereotypical leadership behaviors were viewed as stiff, scripted, dishonest, and nakedly power hungry. Those are quotes from how people described her in the media. Because she was acting counter to gender normative behavior, she suffered backlash on her likability. And similarly, we saw this in our study. While residents recognized the clear leadership skills of the female co-team leader, she still rubbed them the wrong way, and it led to a different perception of the leader. In this study, we also, in our interviews and talking with the residents, discovered that there was this common theme of a vicious cycle of bias. So residents described this cycle of bias against female leaders. And so this quote is, it doesn't affect their ability to be a code leader, but it depends on what setting they're practicing in. This is regards to their gender and the respect that other team members have for that person. So if they were in an environment where there was more prejudice, whether overt or implicit against women, I think that they might not have as much respect as a code team lead. Maybe other people would try to fill their role instead of the code team leader take the lead. And so this resident was describing behaviors that a team leader might have that lead to perception from the team members, and that's influenced by the bias that the team members might have towards that co-team leader's identity. And these then perceptions can then affect the co-team leader's behavior negatively, which continues this cycle of bias. Finally, in this study, we were wondering where are trainees learning how to be a good co-team leader? Because if we could identify that, then maybe we can develop ways to intervene and mitigate the development of these stereotypes and hopefully mitigate the bias. So we asked residents, and they most commonly reported that they learned how to be a good code team leader from observing real codes. from simulation sessions, and from ACLS training during their residency. So that brings us to the second point of this talk about how simulation can build an inclusive learning environment is how it can represent an inclusive population. So we did a video analysis of team training videos. We analyzed 2 common team training curricula that use simulation as an educational modality, specifically looking at the gender of co-team leaders in their training videos. And we found that we identified a total of 85 actors playing health professionals. 50 of them were women and 35 were men. And we identified 18 out of the 85 were playing physicians. And of these, 5 were female and 13 were men. So showing that that predominantly men are represented as the leaders, the co-team leaders, and as physicians in these videos. And I just want to point out that in 2020, there was an update to our AHA training materials. So for those of you who have renewed recently or taken PALS recently, you will notice that the PALS training videos, there's actually a female co-team leader who is in many of the videos, and the expert narrator who describes the science behind resuscitation is also a woman. So slow but steady change. And in simulation, it isn't only about representation of the healthcare team, but also representation of our patient population. So again, I'd like you to think back to the last time you had a PALS course or a BLS class. What was the color of that mannequin skin? And so my guess is that it looks something like this. But in the last few years, there have been numerous models of mannequins that have different skin tone options, allowing us to better represent what our patient population looks like. And also, our patients are represented in simulation through simulated patients or standardized patients. And these are actors, again, who are trained to play the role of a patient or parent in a clinical scenario. And so I think many of you have probably interacted with a standardized patient sometime through your training, whether it was in your USMLE clinical skills test, or during your OSCEs during medical school, or during nursing school or pharmacy school, as it's become a pervasive part of our training. And I want you to think about what color the actor's skin was. And when I think about the last time I interacted with a standardized patient as a trainee, it was a white man. As a facilitator in our CAMBAR center, the last standardized patient was a Black man. And so I just want to show and give a shout out to our standardized patient team at the CAMBAR Center for Simulation up at Parnassus, who, and this chart is showing the change in the demographics of our SP pool, meaning the group of actors that we, or standardized patients that we pull from to do for cases. And so this starting in 2016, there's a gap in 2020 in the data, but as you can see over time, with conscious effort, we've been able to recruit more people of color into these roles, more mimicking the demographics of the area in the Bay Area, as well as California at large. And another question that came up was throughout this work was thinking about, what do the standardized patients think about their role in representation and their role specifically in mitigating bias? So in an interview study that we did with standardized patients, we interviewed them to ask them about their experiences with bias in the student SP encounter. And through this, they identified many ways they can help mitigate bias. And 2 of them that really rose to the top were challenging stereotypes and providing representation. And so challenging stereotypes were one standardized patient discussed how she is of Muslim faith, but that she she tries to represent that Muslims aren't one type of person, and that there is a range of how they can present themselves. And she takes pride in that she can maybe present as a Muslim that isn't what people stereotypically think of. We can think about this also in how we write our scenarios for for any of those in the audience who are educators and writing clinical simulation scenarios, thinking about what does it mean to have the opiate overdose be a old or a young white man instead of a young Black man, and just being conscious and thinking about and reflecting on how we write these scenarios and how we can mitigate any bias or at least not perpetuate any biases that already exist in our society. And then providing representation, just that, you know, these patients can have, patients from multiple backgrounds can all have a variety of health care needs, and that it isn't just one type of patient or of one gender, of one color, of one whatever that needs our help. So I'm gonna spend the rest of the time talking about how we can address biases and in our healthcare learning environment, and how we can use simulation to train people to address these issues. And so the Sneha Daya and Tushani Alangasakare were two simulation faculty scholars this past 2 years. And they were trying to answer the question, can we use simulation as an educational modality to teach skills related to health equity and inclusivity, bias, and social medicine? And so they performed a literature review to answer that exact question. And they included studies that use simulation to improve skills related to diversity, equity, inclusion, and they must teach actionable skills to learners. So in their review of the literature, they found many manuscripts that fell under their initial search. But then when it came down to it, only 18 manuscripts out of the 1,300 initially identified satisfied the inclusion criteria. And many were excluded because they actually did not teach tangible skills on how to address issues around diversity, equity, inclusion. And so they essentially found that while this work around diversity, equity, inclusion, simulation, and anti-bias work is evolving and becoming an educational priority, there's still a scarcity of programs that work to transition perceptions, awareness, and attitudes towards actionable items. And so this is a framework to think about how to become, move from being a bystander to racism, sexism, any ism or bias that occurs in our healthcare system, to an active ally. And a lot of what is being done is at the level of the passive bystander, passive, where someone is educating themselves on the biases they might have, they're doing self-reflection, but really, how can we use simulation to move from here to knowledge and understanding to more behaviors, to acting, to doing? And simulation is a great tool to do that, to practice actual behaviors and skills. So I want to spend some time talking to you all about a local simulation program that we designed to hopefully move from just changing attitudes to changing behaviors. And so I want to discuss the Code Care Support Team Simulation Training Pilot Program. And for those of you who might not know, that the UCSF Benioff Children's Hospital San Francisco Code Care Support Team was initiated after multiple encounters at our hospital led to unnecessary use of force against patients and families that were influenced by bias, disproportionately affecting our families of color, particularly Black families. And in this development of this pilot program over the last year, simulation was identified as a useful tool in training the members of the Code Care Support Team. And so the Code Care Support Team is made up of social workers, nursing supervisors, and spiritual care providers. And they are called to come to the bedside when a patient or provider or staff need extra assistance or emotional, psychosocial, behavioral support. And so we developed these simulation scenarios, and we identified these scenarios by talking to our collaborators and colleagues in social work and nursing. And we developed these 6 set of learning objectives for our scenarios. And we really tried to take an anti-racist lens in how we facilitate the conversation and make sure that race was at the forefront of the discussions in these scenarios. And here's a screenshot of one of our sessions. So we had 2 pilot sessions with a total of 20 people involved. 8 were active participants. In this screenshot, you can see one of our nursing supervisors and one of our social workers interacting with Asia at the bottom, who is a simulated parent. And in this scenario, the bedside nurse called a code care after Asia refused to allow her to take the vital signs of her child and yelled at her to leave the room. And in development of this scenario and in training sessions with our standardized patients, we developed a deep backstory for Asia, where she was wary and mistrusting of the medical system after a medical provider threatened to call CPS after she had missed multiple appointments. And so after we went through the scenario, so there was about 10 minutes of them meeting the parent, trying to listen to them empathetically, figure out what the problem is and come to a resolution. We then had a debrief. And in this debrief, you can see many of my collaborators. So up in the top right is April Edwell. Here is Sneha Daya and Don Pizzini from nursing. And then we have 3 actors in this scenario. Actually, there were 2 parent scenarios and then an actor playing the bedside nurse. And during the debrief, we challenged ourselves to ask questions that were hard to sometimes ask. And so some of the questions were, that we asked the participants, what were moments where you felt like you wanted to respond differently? And how do you think race, ethnicity influenced how you responded to this patient? And we also, I think the value of this situation or this setting, using simulation in this setting, is that we were able to engage with the standardized patients or the simulated parents in the discussion and ask them questions like, what statements did the participants say, did the nursing supervisor say, or the social worker say that really resonated with you? And how do you think race, ethnicity influenced how you interacted with the team or how the team interacted with you? And it really led to a lot of, I think, thoughtful, reflective, and interesting discussions about bias in our system and how we communicate with each other. And I think one of the, and I'll delve into that a little more in the next couple slides. So we did a post-session evaluation of this work. And we asked them these series of questions, and 100%, almost 100% of all the questions were rated as strongly agree. So they felt like these scenarios were relevant to their job. They felt like the scenarios were realistic. They would actually wanted to come back and do it again. And they would recommend this to a colleague. And so that was, I think, strong reinforcement for us that what we were doing was worthwhile. We also asked them these self-efficacy questions. So before and after the session, on their confidence and their ability to, oh, I'm sorry, this didn't show. But the last, their approach of a family who is in distress, approach a colleague who's in distress, and then and recognize my own biases, use anti-bias tools to evaluate a situation, and then talk about race with colleagues at work. And while none of these were statistically significant, because we only had 8 participants, we did see that there was a slight increase in all of these between the sessions, or during the sessions. And again, my favorite part of any evaluation or survey is really reading the quotes, because they carry so much more depth to them, or they have so much more depth to them than the numbers through the surveys. But this was one of the quotes that I pulled out from the evaluation that sort of represents, I think, what a lot of people were saying during or after the session. So discussing with the group, the conversation I had with the sim parent was incredibly valuable. To hear that feedback in real time was very impactful. In the few hours since our training, I have thought about it. In new ways to say things to families are already coming to me as a result of this experience. I appreciate the open discussion about race and definitely identify ways to overcome my fear of addressing this directly with patients and families. So I wanted to say that we have what we have learned as a team from this work is that this work of teaching skills to transform people from passive bystanders to active allies is really hard. There's definitely ups and downs and a lot of barriers, and definitely mistakes have been made. And we have to get up from those mistakes and learn and push through these obstacles to continue this work, because we believe it's important, and this work will improve the learning environment for everyone and the clinical care of all of our patients. So I hope that in the last 40 minutes, I was able to convince you that that simulation is a powerful tool that can be used to create an inclusive working and learning environment. And through these 3 mechanisms: revealing biases that exist in healthcare, representing a diverse and inclusive environment, and addressing biases through training of healthcare providers. I want to say thank you to a lot of people, including the Department of Pediatric Grand Rounds Committee, my mentor, Sandrine Van Schaik, my division chief, Jeff Feynman, everybody at the Canbar Center, all my co-collaborators who are listed here, the standardized patients that we talked to, the AAMC who funded a lot of this research, and also just to my whole division and all my colleagues and many of you in hopefully, I know many of you are in the audience, and many of you have been allies for me, and I appreciate everything that you've done to support me through this work. I also, since I have a little bit of time, wasn't sure how long this is going to be, wanted to put a plug in for microaggressions training. I think it's a training series, a series of workshops that are for GME faculty leaders that are focused on practicing skills and addressing microaggressions in the teaching and learning environment using simulation. And this is led by Sneha Daya and April Edwell and Jenna Esikow. If you are a GME faculty leader, please sign up for these. And the hope is eventually, I think Sandrine can speak more probably, to grow these programs to be offered more broadly. Thank you. And I finished early.
Thanks so much, Mindy. That was really great. And I forgot to mention in the introduction, but Mindy, in recognition of all the fantastic work that she's done in such a short period of time, because she really only came to UCSF 5 years ago as a simulation fellow and has been on faculty for 3 years, was inducted in the UCSF Academy of Medical Educators, which is really a great honor that is so well deserved. This is now open for questions. I see some questions in the chat. If people wouldn't mind using the Q&A function so that I don't have to look at 2 different places for questions. But the first one says, amazing work, Mindy. Thank you so much for doing it and sharing it with us. That comes from Dr. Elizabeth Rogers. And then our friend and colleague in simulation from the School of Nursing, Annette Carley, she says, in the data slide, it appeared that 3 out of 8 responded neutral to the question regarding the session meeting expectations. And I think this refers to the Code Care program. What are your thoughts on this?
I believe it's that I don't think it was neutral. I think it was agree, not strongly agree. So I'm not exactly sure what, we didn't delve into what they were expecting from the session, but something definitely we could investigate more. And as we hopefully build out this program, where we would like to do more sessions, but are looking for support in different venues to continue this work.
If there's other questions for Mindy, please put them in the Q&A. Maybe in the meantime, I can ask a question that I kind of sort of know the answer to, but not fully. So what are next steps, both because you showed very nicely how simulation can be used for research, but also to address some of the issues. So what are your next steps in each one of those domains?
That's a great question. I am hoping to, I really want to build out this code care support training, which I just mentioned earlier. And it requires what we learned from a lot of this work in simulation through the microaggressions training that has been done, and also through our work, is that this work requires a lot of training. It requires time to train facilitators appropriately. It requires emotional, physical, and mental energy from the facilitators and from the program designers. And that all is time, and it requires a lot of time. And so we're hoping to gather support from different places to continue doing that work, because we think it's valuable and important, and it seems like our participants do as well. So that's one thing that I want to continue pushing forward in terms of how we address how we use simulation to convert people from passive bystanders to active allies. Another thing that I've been thinking about and starting to work on is the concept of male allyship, and how we can engage more of our male colleagues in a lot of this work, not just the gender work, but also the race and the racism work. And I think I can say this, but I know that the first round of this GME microaggressions training, there were 50 participants who signed up. And I think 2 were men, one of whom was Dr. Duncan Henry. So hats off to you, Dr. Henry, for joining and participating in that. And so I'd like to understand more the barriers to male allyship and perhaps develop, once we understand that through qualitative interview work, develop workshops or simulations or other things to help bring in that male allyship. Did that answer your question?
It did. Thank you so much. Yeah, the question, where are the men with these initiatives, is certainly an important one that's been on my mind as well. But one man is asking a question on the Q&A, and it's our colleague, Dr. Jim Howard, who is the simulation director on the Oakland side of things. And he asks whether the code care scenario training can be extended to bedside providers.
We had talked about that. We wanted to start small with a pilot group of the people that were actually on the code care team. But we have heard from our nursing colleagues that, and I think even I'm sure many of our frontline providers who have to be the first to engage with these challenging situations, that they would love this training as well. Again, it's very time intensive. Each session is 2.5 hours or 2 hours, and they probably need to be longer because one of the most common comments is like, we need more time to talk about this. And so just need to find the support to do it so that people, so that we can continue spreading this work.
I guess the next question segues nicely into that time intensive piece of it. It's from Dr. Christy Buscarden from the Research and Development and Medical Education Office at the Center for Faculty Educators. She's asking, well, she's saying awesome presentation and work. What are your thoughts on virtual reality as a tool for DEI training?
I think it's great. And I know nothing. I've told this to Sandra, it's like the new frontier, but I feel like as a simulation expert, I don't know much about it. And but I do know that there are people working on that and using VR and virtual reality to reveal biases. So you could create scenarios where they're immersed into a situation and the avatar is of a certain skin color versus another. And in that setting, you really are making all characteristics of the person the same, except for their skin tone. And so I think there's a lot that can be done with VR. I would love to talk to people who know more about how to make that actually come to fruition. And I know there's, I'm sure a lot of ability, there's the potential to do these active trainings where you could be interacting with a person, a virtual person, rather than a standardized patient to practice your skills, which would definitely decrease continuing costs and time. But I think the real time and effort is from the facilitators and the skills that are needed to lead that conversation, which is a varied conversation every time because it's a different group of people in a different situation.
And then Isabella Johnson asks, thank you so much for this study. Would you consider running a simulation qualitative study about perceptions of a disabled or learning disabled providers, attendings, nurse practitioners, or do you know anyone that is looking into this?
I don't know about disabled providers. What I can tell you about the nurse, I didn't go into it because I wasn't sure I'd have time, but apparently I have plenty of time, was the study. We actually had 4 arms. And so there was also the nurse practitioner co-team leader. And the way we identified that co-team leader as a nurse practitioner was we just labeled it in the video. So it came up at the top, at the very beginning of the video, that this is a nurse practitioner. But when we did the survey results, we found that there was actually, we didn't find any difference in the ratings between physicians and between the physicians and the nurse practitioners. And but when we did our qualitative study, we asked a lot of questions about this because we were curious as to why that was. And what we found is that when we showed residents videos that were labeled as nurse practitioner or physician and asked them what was the professional background of the co-team leader, they almost all the time said physician, even if it was labeled as nurse practitioner. So the idea that a nurse practitioner could be a co-team leader was just so out of their realm of reality that it didn't even sink in. They just assumed that they were a doctor. And so we delved a lot into some of that and residents' perceptions of what a nurse practitioner as a leader in the healthcare system. I think
Glenn Rosenbluth is asking, we've been successfully at offering monthly mock codes on a monthly basis and making them mandatory. Do you envision this training ever reaching that level?
That's a great question. The issue with mandatory and this work is this is one of the lessons we've learned from the last year and a half of really pushing this simulation and DEI work, is that when you make these trainings mandatory, and even non-simulation trainings, when you make anti-bias or unconscious bias trainings or DEI trainings, whatever you want to call them, mandatory, you can actually have reinforcement of the behavior that you actually are trying to address. And so there's a lot of business literature on this, and that like actually inclusivity goes down after they make all these sessions mandatory. And I think so there is potential harm in that sense to make them mandatory. The other thing about making them mandatory is what we've learned, or what I've taken away, and I'm sure other people, maybe even listening to this, have experiences, but that what we learned is that on this journey of becoming more inclusive, each individual's journey, we're all at a different place. And there are some people, particularly people of color or from marginalized backgrounds, who this can be traumatizing to them to go through these kind of trainings where they see microaggressions or other experiences or microaggressions being perpetrated, and it can be traumatizing to because they've personally experienced it, and they're at a different place in their journey than other people. And so making it mandatory could be quite detrimental to them. And the last thing we want to do is cause harm to anybody through these trainings. I would love it though if it was so popular that people would want to come to it monthly in the mock code.
All right, another question. Duncan Henry, fantastic presentation, Mindy. Your work shows the power of simulation in understanding and addressing bias, particularly in respect to gender and race. I wonder if you might speculate how one could use this study and address our biases around, that's a word that I don't know, ableism.
Ableism.
Ableism. Sorry, that was a moment of learning disability there. I had a moment of dyslexia. Or know if there's already work done in this space.
I don't know of work doing this space in terms of using, I know there is work in terms of using simulation to address biases around disabilities. And I think some of that came through in the scoping review that Sneha and Tushani are working on. But I wonder if you're talking about generating a study to simulate. I could imagine you could create a study where you simulate a child with a a disability versus not, and see how people interact with that child or that parent or that family differently. I'm not sure I'm answering your question, Duncan, but we can chat later too, if if I didn't.
And then the last question is, at least for now, is again by Dr. Jim Howard. And I think I know what he's asking, but I'm just going to read it and then you can decide and I can help if needed. I respected the shift in SP to reflect the population of the Bay Area. I wasn't quite clear how well that shift matches the makeup of the Bay Area and even patients that present to our different healthcare facilities.
I think the question is regarding how the percentage breakdown in the SP pool. And based on the data that I had seen, we are getting close to we're getting close to the representation in our pool of that is represented in the Bay Area. I don't know exactly how we define the Bay Area, but the group that is not represented to how it's represented in the Bay Area is Asian Americans, actually. And you bring up a good point though, because those that come to our hospitals, especially maybe, and perhaps you're referring to differences between each side of the Bay, the makeup might not actually be representative of the total population in the Bay Area. And so those are interesting points to bring up and continue.
I think it's important to realize that our simulation center provides training services for students across all of our health systems, right? They go everywhere. So I think in the end, a representative sample of the Bay Area is more important than of one particular health system.
Yeah.
All right, Mindy, I think you managed to generate a lot of discussion and good questions. And I think we've the end of our questions, although Dr. Hirsch might have a question.
Yeah, we do have 2 minutes left, and I do have a question. First of all, Dr. Ju, I want to thank you for a really powerful presentation, and I really applaud the important work you're doing. My question relates to some of the data you showed early on, which if I understood it, when you were showing the initial data on biases that people had about who would be leading a code, for example, that people were biased towards males in that role in their conception of who's in that lead role. And it looked like you had participants from various departments across UCSF. And I'm just curious whether you were able to split that out and look specifically about the Department of Pediatrics, because we have more women than men in our department compared to other departments. And I imagine that a lot of this may have to do with role models that people have had during their training.
That's a great question. So it wasn't, I didn't probably explicitly say this enough, but we recruited not from the Department of Pediatrics because the scenario was a myocardial infarction. And so, it was a very much leading to VTAC. So it was a very much an adult case. So we wanted to be the adult trainees because some of it was mistakes were made in following the ACLS algorithm. And so we made an imperfect code team leader. And so we wanted at least the people watching the video to understand what the ACLS algorithm was. But we didn't actually, it wasn't powered enough to look into each individual department. And so we didn't see any differences that were statistically significant. And we didn't find any difference based on gender, meaning a female looking at a female video wasn't more, didn't rate them higher than a male resident viewing a female, indicating, which is I demonstrated in my story, is that even women have an internalized view that isn't thinking that women are natural leaders or the ideal co-team leader. Because when I close my eyes, I lead codes, and when I close my eyes, I don't picture myself or a woman. So it's an interesting thought, but I think it just, and I agree that the role modeling issue came out with that chief resident, like the description of her came out multiple times with different residents. So it's true that role modeling is a huge factor in this.
Well, thank you again. This was really a very interesting presentation and a lot of food for thought and things to be working on moving forward. So thanks to everybody for participating today, and we'll see you all in a couple of weeks at the next grand rounds. Have a good rest of your day.